Hello and welcome to ADAA's educational webinar, Frequently Asked Questions About Ketamine. My name is Jolie Busby and I'm the Education and Training Manager here at ADAA. I'm very pleased to introduce our speaker, Dr. Allison Wells. Dr. Wells is an anesthesiologist and an experienced leader in ketamine treatments for mood disorders and pain conditions. She founded one of the first focused clinics in the country and has helped many patients with many thousand infusions and actively contributes to the field with research and advocacy. Wells Medicine provides interventional procedures and a focus on comprehensive mental health with treatment, support, and a robust referral network toward excellence in evidence-based care. Welcome, Dr. Wells. Thank you for speaking with us.
Oh, thank you for having me, Jolie.
So you recently had a blog posted with ADAA, which we are very grateful for, on the topic of ketamine as a rising star in mental health treatment. And it prompted some questions about the treatment that we hope you can shed light on today.
Sure, happy to.
So first, how does ketamine help?
So ketamine is an NMDA receptor blocker. And so we have NMDA receptors on our cells. And when those get blocked through the use of ketamine, then the downstream effects of blocking that receptor mean that there's a surge in a chemical called BDNF alpha, which is brain-derived neurotrophic growth factor, and there's a surge in glutamate, and those things cause neural cells to grow new connections to other neural cells. So that's one of the ways that they think ketamine is helpful, is that it causes neurogenesis, which decreases the fight or flight paths that we can find ourselves in when we're under stressful conditions. And the adrenaline, the cortisol, those pare down the neural connections until we have very rigid thinking, very inflexible thinking, and very much on those narrow fight or flight pathways. And the ketamine, like growing leaves on a tree in springtime, fills in those sparse neural connections. And that's one of the ways they think it can be helpful. Of course, there have also been papers written that ketamine affects AMPA, it affects mTOR, it affects the opioid mu receptors. So there's lots of ways it possibly can be effective just biochemically, but then also psychologically, ketamine seems to give patients who are sort of stuck in therapy a greater perspective on their problems and a little bit more distance and clarity. In cognitive behavioral therapy, we would say they defuse from their thoughts for a minute to be able to kind of see them as separate from their reality. And so that can be a tremendous benefit from the patients psychologically that maybe has something to do with the biochemical receptors, but we're not entirely sure.
So interesting. Well, what exactly is it used for? To follow up, and when would it make sense to consider the ketamine treatment?
So ketamine has been studied and has published research papers on treatment-resistant depression, severe generalized anxiety disorder, OCD, PTSD, and bipolar disorder. There are lots of other things people are investigating it for, anorexia nervosa, medication-induced depression, lots of other things that it's being investigated for, but the ones to really focus on, because we have so much data behind them, are really treatment-resistant depression, severe anxiety, OCD, and PTSD.
Well, in general, and you may or may not know, but is it generally covered by insurance?
So that is a great question, because a lot of people confuse that with a question that does it have FDA approval? And so those are separate questions that I really want to address. So one, ketamine IV as administered in most ketamine clinics is not generally covered by insurance. even though ketamine intranasal has FDA approval for suicidality and depression, that is variably covered by insurance. And I say variably because a lot of the insurances will say they cover it, but if you try to get a patient through the hoops to get it covered, it can be very, very difficult to actually obtain coverage, even when clearly the patient in front of you deserves coverage. But having said that, a lot of the ketamine clinics work as out-of-network providers, because even though the intranasal ketamine is approved, the IV formulation of ketamine is not approved by the FDA for depression and for suicidality. So it's still considered experimental treatment, even though there are more than 500 studies and more than 20 years of data. But I like to tell my patients, insurance companies don't need FDA approval to pay for medications. They need pressure to pay for medications, because up to 1/5, 20% of all medications prescribed are what's considered off-label. So the FDA has approved them for something, but we're using it for something else, and insurance companies still generally pay for those. So for example, if you use propranolol, a blood pressure medicine, for tremor or for social anxiety, that is an off-label medication, but it's covered by insurance. So it really depends on what the insurance companies want to pay for. We provide our patients with what's called a super bill. So it's an out-of-network list of charges. And a lot of them turn that into their insurance companies, and their insurance companies will pay for the doctor visit, or they'll pay for the treatment time. So we encourage them to seek reimbursement. A lot of us in the community worry that if it was covered by insurance, it would have some of the same problems Spravato does, where it doesn't always align with what you think that service is worth in your clinic setting. So if they did cover it, our concern would be that they would cover it at a cost that we wouldn't be able to provide the service for.
Always a very complex side of treatment insurance. Well, thank you you did a good job of explaining as best you could where things were. Well, let's talk about the procedure itself, and how is it administered and how often?
So the steps of the procedure, first, someone has to be at some point diagnosed. And a lot of ketamine clinics are run by family practice doctors, ER doctors, anesthesiologists. So we always prefer someone with a degree in psychology, psychiatry, MHNP, to diagnose a patient. Because it's generally studied in treatment-resistant depression, usually patients have been in care, tried a few different medications, tried a few different therapies, and then that's when they would be considered a good candidate for ketamine treatment. So I always laugh, we're never anyone's first Prozac, right? So they've been in treatment, they've been in therapy. Just nothing is really seeming to be helpful, or helpful enough, or they're not tolerating the side effects of the medications. And so, when you have a patient who fits those criteria, then they can either self-refer or be referred to our clinic. They fill out all the new patient paperwork. We make sure that there's nothing that would disqualify them for ketamine treatment. Something like untreated hypertension, recent heart attack, recent stroke, untreated glaucoma, seizure disorders, really severe sleep apnea, something that might make them unsafe to have a light sedation in the office. And then they come in, we have a nice discussion about the risks and the benefits and what to expect, and some things that can make it better and more helpful, and some things to expect out of the treatment. We start the IV. It's a 40-minute infusion. And then at the end of the 40 minutes, we turn off the IV, disconnect them from the EKG that we've been watching, the pulse ox monitor that we've been watching, the blood pressure cuff that we've been watching. And then they sit for about another 20 minutes or so, and then they can go home. The infusions are given generally in a series. Originally, it was studied 6 times over 2 weeks, but data from our clinic was published, as well as some other recent studies that show that once a week is okay, twice a week is okay. All of those seem to be about as effective as 3 times a week for 2 weeks. But getting to 4 to 6 and then starting to space farther and farther from there until they need, after the first 4 to 6, we can go to about every 3 to 5 weeks. And then we sit at about monthly maintenance. So some patients just really love not having to take a pill every day. Some patients really love not having the side effects from some of those pills every day. So once you can get to about that monthly maintenance, that tends to be the sweet spot for a lot of people, but some people will just come and do the 4 to 6, and then we'll see them, you know, if their dog dies or they lose their job or something else kind of comes up for them.
I see. And you mentioned side effects of other medications. What are some noted side effects of ketamine?
So during the infusion itself, most of the side effects of ketamine are contained during the infusion itself. So we see about a 20% rise in heart rate and blood pressure. We see nausea. There's definitely, and I wouldn't always necessarily consider this a side effect so much as an effect, but definitely people can have very vivid visions, hallucinations, feelings like they're floating, or an out-of-body experience. Some people consider that part of the benefits of the medication, but definitely it's a very vivid experience.
That is very interesting. I personally did not know about those side effects. So what are the potential benefits? You've talked a little bit, but how does a patient know if it's working?
So they know pretty quickly whether it's working or not. There's a very typical pattern of ketamine treatment. So after the first treatment, it can be kind of subtle. It's not a light switch. But after the first treatment, generally patients will sort of acknowledge they feel like they are having less negative thoughts. Suicidal ideation decreases very rapidly. Negative thoughts decrease very rapidly. And that generally, after just the first treatment, would generally last 72 hours to about 2 weeks. After the second treatment, often their circle around them notices you're doing more. You called Aunt Bertha, you picked up the phone, you went to go to Sephora, you know, you're doing things, you're out, you cleaned your room. So they see this sort of movement. And then by the third one, that's when patients come in and they're like, okay, the sky looks blue again, I'm sleeping again, I'm interested in things. I haven't started bowling again, but I got my shoes out. They're really starting to, you know, see the progress. And so then it kind of continues through 4, 5, and 6. But that's our pretty typical pattern.
That is very helpful and good to hear. Well, one of the things that, or one of the questions that comes up a lot for ADAA is discussion of a major depressive disorder. And a question that came to us about ketamine is it possibly a frontline treatment or only after an SSRI is tried first?
So there is some discussion in the ketamine world of, well, why would you have someone, you know, waste time on an SSRI, or why would you have someone, you know, have to try these medications first? Ketamine really has only been studied for treatment-resistant depression. And in treatment-resistant depression, 70 to 80% of patients see a reduction of symptoms by at least 50% over the first 2 or 3 infusions. Now, the question is, would that still happen in major depression that isn't treatment-resistant? It's very hard to know because nobody is giving this as a first-line drug. If you can take a generic Prozac at home for $20 a month and you do fine with the side effects and it fixes your depression, great. You know, I say try that first. I'm also a big proponent of try, you know, heavy duty exercise first, try some cognitive behavioral therapy first. All of those things are additive, and we try to encourage patients, you know, make sure that this is this is complicated. You have to have a driver. It's expensive, it's time consuming, it's certainly intense. So I don't think it really fits as a first line medication or therapy. I think therapy is a great first line option.
Well, and thank you. That actually is a great segue for my last question, which is, are there things that make ketamine less effective or more effective as a therapy?
So we talk about this a lot in treatment, and ketamine is an amazing molecule, and it has a very good biochemical reason for why it works. There are lots of amazing molecules that make wonderful changes in your brain, but that is only part of the ecosystem of your life. And so things that make ketamine more effective, I think therapy, having a therapeutic relationship, being in therapy, having someone to bounce these things off of when they're coming up for you during ketamine treatment, making lifestyle changes like getting good rest and prioritizing sleep, eating a good diet, making sure that you are reducing stress and having some mindfulness or prayer or meditation. I think making sure that you're optimizing your vitamins. So many people come in and they're vitamin D deficient, or so many people come in and they don't have B12 or methylfolate. And it's like making sure that all of those things are kind of keyed in as well. So those things make it much more effective. Some of the things that make it less effective, heavy use of marijuana. I see this all the time, even though this is Texas, it's still not legal here. But people underestimate it as an effect in their mood. So heavy use of marijuana, benzodiazepines can really decrease motivation, decrease drive. They seem to slow down the effectiveness of ketamine and delay it by 1 or 2 infusions and decrease the duration of the effect. And there's some reasoning behind this, that benzodiazepines are GABA agonists, and ketamine downstream on one of its many receptor pathways hits the GABA system. So there is kind of a reason for that block. Heavy alcohol use for the same reason as benzodiazepines, because of the GABA agonism, because of the motivation, because of the leaning on something and avoiding good things in your life. And then there's some question about medications like Lamictal. We have very variable response to patients with ketamine on Lamictal. I can't say for certain that it's not a good response, but it's very variable in patients. And then a lack of support. So if you're in the middle of something completely awful, and your family is not supporting you in this treatment, and they're very against this treatment because it's an animal tranquilizer, or it's a street drug, or any of the other things that people can be, in some cultures, they're chin up and bear it, and any kind of therapy is looked down on. So if that's part of a lack of support, that definitely can play into not doing as well with ketamine as someone who really has that social network and support.
I really appreciate that. When we close out this webinar today, there will be some resources that I share with our viewers to find some of those resources and links to treatment and peer-to-peer support, finding a therapist rather. I just want to say thank you so much for sharing your expertise with us today. This has been a very informative and helpful interview and discussion with you, and we hope to have you back again sometime.
Oh, well, wonderful. Happy to. Yes.
Thank you. The Anxiety and Depression Association of America works to prevent, treat, and cure anxiety disorders and depression through the alignment of science, treatment, and education. We invite you to explore our website at adaa.org, where you can find resources such as a Find Your Therapist directory, free evidence-based webinars, blogs, and videos such as this one, ADAA's free online peer-to-peer communities, self-help books and publications, And we also ask that you consider subscribing to our free monthly e-newsletter, Triumph. On behalf of ADAA and our presenter, Dr. Allison Wells, we thank you for joining us.